Hey, this is part 2 of the lecture on OCD. In the previously recorded part of the lecture, I talked about what OCD is and described some of the presenting symptoms and symptom clusters by identifying common themes in the patterns of obsessions that people experience and in the related compulsions. In this part of the lecture, I'm going to talk more about the etiology of OCD, talking a little bit about some of the neurobiological vulnerabilities that are specific to OCD. Although it's important to remember that OCD is, while not an anxiety disorder, it involves maladaptive experiences of anxiety and avoidance, and therefore it shares a lot of predisposing factors with the anxiety disorders, and those we won't really discuss. I'm also going to speak a little bit about precipitation. Less is known about the specific precipitants of OCD in most cases, although in the next couple slides, I'm going to talk about one example where theoretically the precipitation is very clear and specific. In general, we can think of OCD as kind of a neurodevelopmental disorder where symptoms tend to start relatively early in life, as I talked about in the last part of the lecture, often in about 25% of cases before puberty. And we can think about the development of pathological OCD symptoms as being precipitated by, for example, life stressors or developmental maturation processes in the brain that essentially overcome the individual's ability to cope with their neurobiological vulnerabilities and result in the appearance of OCD symptoms. The bulk of this lecture is going to focus on perpetuating factors, and whereas OCD is a very neurobiologically loaded disease, the perpetuation of the symptoms is very cognitive and very behavioral, which means that cognitive behavioral treatment is the treatment of choice for OCD. So we'll talk about the role of cognitive distortions in OCD, and then we'll talk about the role of compulsive behaviors in maintaining and perpetuating OCD symptoms. Okay, so first I'm going to talk about an example of the precipitation of OCD where there is a theorized known precipitant, and this is the case of OCD that develops after viral disease, especially streptococcal infections, known as pediatric autoimmune neuropsychiatric disorder. Following a strep infection, some case reports describe what's known as explosive onset of OCD or disordered eating, food restriction, in the 48 hours following the onset of strep infection symptoms. This syndrome, this OCD that develops in the context of strep infection, is known as pediatric autoimmune neuropsychiatric disorder. To be diagnosed with pediatric autoimmune neuropsychiatric disorder, or PAN, the onset of psychiatric symptoms has to be very sudden. It's often very severe, and it has to be concurrent with an active infection. And this is really important because strep is actually very common. So some evidence that there is an association between having a strep infection and the precipitation of OCD symptoms is that children who are diagnosed with OCD, with tic disorders, and with eating disorders are 16% more likely than other kids who don't have those disorders to have tested positive for strep at some time in their life. The study that this data is from didn't actually tie the timing of onset of symptoms to the timing of the strep infection, but because kids with OCD, tics, and eating disorders are significantly more likely to have had strep in the past than kids without these disorders, this piece of evidence points towards strep playing a role in the precipitation of symptoms for at least some kids. However, a piece of caution is that kids who test negative for strep are also statistically significantly more likely to have OCD, tics, and eating disorders than comparison kids who have never tested positive for strep. And the reason for this is that obviously physicians, pediatricians, psychiatrists, and psychologists know about the existence of pediatric autoimmune neuropsychiatric disorder, and often kids with OCD, tics, and eating disorders, especially but not always when those symptoms have a sudden and severe explosive onset, end up getting tested for strep to rule out or rule in pediatric autoimmune neuropsychiatric disorder. So the short answer is the reason that kids with OCD are more likely to have tested both positive and negative for strep is that kids with OCD are more likely than other kids to be tested for strep at some point in their lives. But again, strep is a very common childhood infection. Probably many of us have had a strep infection at some point in our lives, sometimes without knowing or having been tested for it because it goes away on its own. So in order to diagnose someone with pediatric autoimmune neuropsychiatric disorder, and in order to be sure, or as sure as we can be, that strep infection precipitated the onset of OCD symptoms, the onset has to co-occur with an active strep infection. Otherwise, it's not PANS, it's just OCD and strep co-occurring, which is going to happen in some percentage of the population because strep is super common and OCD is relatively common with about a 2.5 to 3% prevalence in the population. So another piece of evidence for the role of strep in precipitating OCD symptoms is a specific biological pathway or mechanism that could explain why strep infection precipitates OCD. So in this schizophrenia lecture, we talked a little bit about the concept of autoimmune encephalitis. Encephalitis just means swelling of the brain tissue, and autoimmune means the immune system essentially attacking the body's own cells. So autoimmune encephalitis is encephalitis caused by an autoimmune process. And the example that we've already talked about as a precipitant of psychiatric symptoms is anti-NMDA receptor encephalitis, which can precipitate psychosis symptoms. In anti-NMDA receptor encephalitis, the body attacks its own NMDA receptors, which disrupts dopamine transmission in the brain and causes the positive symptoms of schizophrenia. The autoimmune theory of PANS, pediatric autoimmune neuropsychiatric disorder or syndrome, suggests that the body produces antibodies to strep that inadvertently attack cells in the basal ganglia. There's some evidence that strep antibodies interact with anti-neuronal antibodies or antibodies that specifically attack neuron cells, and that this process specifically happens in the basal ganglia, which is a part of the brain that's involved in initiating and controlling intentional movements, and which, as we'll talk about later, is very involved in biological vulnerability to OCD and to some extent involved in the perpetuation of OCD symptoms. So we'll get back to that. I just wanted to give a quick example of one of the few instances where OCD has a known specific precipitant. I should add, though, that the existence of PANS is somewhat controversial. I would say that most people who work with OCD believe that PANS exists. There definitely are cases where OCD symptoms occurred explosively in the context of a strep infection. And often, as we'll talk about later, OCD symptoms actually go away when the strep is treated. This does give fairly strong causal evidence that the strep has something to do with the onset of OCD symptoms. However, when strep isn't related to the onset of OCD symptoms, treating strep with antibiotics or treating an autoimmune process with therapies like IVIG and other relatively invasive immunotherapy treatments is not indicated. Yet this is actually a fairly common thing that people who are desperate for help with their OCD might be vulnerable to kind of falling for. There are physicians who are sort of unscrupulous and who ascribe all types of OCD symptoms, eating disorder symptoms, and tics to an underlying strep infection and treat that strep infection inappropriately. Because as we'll talk about, the appropriate treatment for OCD is cognitive behavioral therapy, sometimes in combination with selective serotonin reuptake inhibitors. Okay, so now I'm going to talk a little bit about the role of cognitive distortions in obsessive compulsive disorder. Okay, so before we talk about the specific role of cognitive distortions in OCD, I want you to think about whether you've ever had any of these experiences. So have you ever had a pang of anxiety that maybe you sent an important email or text to the wrong person, or maybe hit reply all on an email that was only meant for one person? Have you ever felt like your hands were just kind of physically dirty and there was just a feeling about them that was off after touching something like money or gas station pumps or the pole in a subway? And have you ever been not completely sure if you actually remember to do something like turn off a stove or lock a door? All of these are examples of common intrusive thoughts, both for people with OCD, but also for people without OCD. Having these thoughts and having these doubts is very normal. So here's how cognitive distortions play into the maintenance of OCD. Intrusive thoughts, like the ones on the previous slide, are completely universal. Other examples include questioning whether you remember to turn something in on Canvas, having anxiety about something like, what if I stop loving my partner, worrying about hitting reply all when you send an email, even sometimes having weird intrusive thoughts about what people look like naked or unwanted sexual thoughts. All of these things are very common. People with OCD care about the same things that everyone else cares about, and they have the same worries that everyone else has. Everyone wants to be clean, everyone wants to be safe, everyone wants to know that their things are where they're supposed to be. Everyone wants to know what to expect from the world, from other people, and from themselves. So if all of these experiences are universal, why don't we all have OCD? One explanation is that distorted beliefs, cognitive distortions, help to explain why people with OCD experience these relatively common intrusive thoughts and relatively common normal concerns as so distressing and intrusive that they motivate compulsive behavior. So let's talk about some examples. I'm going to argue that cognitive distortions represent underlying beliefs that can help us to explain why obsessions, which again have content that everyone thinks about and everyone cares about, why obsessions are so uniquely distressing for people with OCD. And I'm going to talk about a couple categories of cognitive distortions in OCD that actually map onto the major symptom categories that I talked about in the last recorded lecture. So one category is responsibility. People with OCD have an overinflated sense of their own responsibility for events in their lives and their own responsibility to prevent bad things from happening. So an example of a cognitive distortion related to responsibility is something like, if something bad happens, it's my fault for not preventing it. Threat overestimation involves basically the cognitive distortion of jumping to conclusions and predicting the worst. So people with OCD are prone to assuming that the worst case scenario is more likely to happen than maybe it really objectively is. Both responsibility and threat overestimation are not really cognitive distortions that are unique to OCD. People with other anxiety disorders, or not other, people with anxiety disorders experience these distortions too. And so these beliefs, if something bad happens, it's my fault for not preventing it, the very worst case scenario is likely to happen, are not unique to OCD. You would see them in people with anxiety disorders too. What gets a little bit more specific to OCD and the OC spectrum, which the broader spectrum includes obsessive compulsive personality disorder, eating disorders, is this concept of a distorted need for perfectionism or a need for certainty. So distortions like, if I don't know exactly what to expect, I can't handle it. I need to know. If something is not done absolutely perfectly, it's not worth doing at all. Or relatedly, if something is important enough, I have to be 100% sure that it's done right. These distorted beliefs are, again, a little bit more specific to the OC spectrum. And then lastly, even more specific to the OC spectrum, and actually sometimes straddling the line between obsessions and delusions, psychosis, is this concept of thought fusion. So these are distortions like, if I think about something, it must mean that I secretly deep down want it to happen. Or the magical thinking belief that if I think about something, it actually makes it more likely that it will happen, like I'm kind of willing it into existence. And then lastly, the belief that having a thought about doing something bad is just as bad as actually doing that thing. The distinction between thought and action is blurred, and thoughts become as morally significant as actions. So these are some of the cognitive distortions that people with OCD experience. So because of these cognitive distortions, normal intrusive thoughts become more distressing for people with OCD than they are for people without these cognitive distortions. When someone who doesn't have an overinflated sense of responsibility questions whether or not they turned off the stove, they're usually able to let that thought go by reminding themselves, I probably did. I always have turned off the stove. I've never made this mistake before. And so, if something bad does happen, it was really kind of out of my control. There was nothing I really could have done to prevent it because as far as I know, I turned off the stove and that's really all I'm responsible for. Or when someone experiences like an unwanted intrusive sexual thought, like inadvertently thinking about what the president looks like naked, most people who don't have these cognitive distortions would be able to kind of brush that off and just be like, well, that was weird. I don't really want to be thinking about that. Whereas someone with OCD with these cognitive distortions might think, oh my God, what kind of person am I that I'm picturing Joe Biden naked? I didn't think that I was attracted to Joe Biden, but I'm having these sexual thoughts about him. So that must mean something about me. Or even having these thoughts is in some way making it more likely to happen. So if I'm having intrusive thoughts about harming someone or harming myself with distorted beliefs about thought fusion, I would actually think that having those thoughts are making it more likely that it will happen. So cognitive distortions help to explain why people with OCD experience normal intrusive thoughts and normal motivations for cleanliness, safety, and predictability as more distressing than other people. This level of distress that people experience about their intrusive thoughts helps to explain why compulsive behavior, so doing things that help to relieve the anxiety and distress that comes with those intrusive thoughts, is so negatively reinforcing. If you're not that distressed by your intrusive thoughts, then anything you do that helps you get rid of them isn't going to be as strongly reinforced as if you are very distressed by those thoughts. Another question, though, is so by definition, compulsions are repetitive. Why don't people with OCD feel better, feel relieved after doing a compulsion just once? What helps to explain why compulsions are repetitive, and how do people actually know when a compulsion is done, when they can stop doing it? Because again, cognitive distortions about responsibility, threat overestimation, and perfectionism to some degree, and even thought fusion are not really unique to OCD. People with anxiety experience them too. What makes OCD more distinct from anxiety disorders is the repetitive, negatively reinforced compulsive behavior that people engage in to try to manage their intrusive thoughts. So one explanation for why compulsions are so repetitive has to do with the concept we've talked about before in the context of generalized anxiety disorder. So we talked about the white bear experiment, where research participants who actively tried to suppress a thought, who tried to not think about something, were A, not always successful in suppressing that thought. Sometimes it popped up while they were actually trying to suppress it. But B, as soon as they stopped actively trying to suppress, they experienced more of that thought than people who had never tried to suppress it in the first place. This is known as thought rebound. When you try to suppress a thought, as soon as you stop actively trying, the thought bubbles back up. So say you're someone who's very bothered by having intrusive sexual thoughts or thinking about the president naked. If you have the cognitive distortion that this thought must mean something, it must mean that I secretly want this to happen, it must mean that I'm some kind of weird pervert who is attracted to Joe Biden, you would be motivated to try to suppress that thought because you think that that thought has really negative implications and you think that actually having that thought is somehow dangerous. So people who have the cognitive distortion related to thought fusion are more motivated to try to suppress intrusive thoughts that they think mean more than other people would think that they do. And as we know, the more you try to suppress a thought, the more you experience rebound thoughts as soon as the active effort to suppress is over. So because thought fusion increases people's motivation to avoid unwanted thoughts, people with thought fusion cognitive distortions are engaging in more thought suppression and experiencing more thought rebound about these intrusive thoughts, which necessitates them to engage in suppression again. And this process of avoiding the thought, relaxing a little bit, having the thought pop back, doing the thing again to avoid it, is the cycle of obsessions and compulsions related to this type of OCD, forbidden thoughts, and this particular cognitive distortion, thought action fusion. So again, if you believe that thinking about Joe Biden makes it more likely that one day you'll see Joe Biden naked, thinking about Joe Biden must mean that you want to be having this thought, that it's somehow enjoyable to you, even if you aren't experiencing that way, or that you believe that having this thought makes you a bad person or a pervert or creepy in some way, you would be more motivated to try to suppress it. But we know that thought suppression doesn't work. So because the thought is continually rebounding, you need to repetitively engage in those suppression efforts. Okay, so another explanation for why compulsions are experienced as so repetitive has to do with what's known as incompleteness experiences. And again, just like intrusive thoughts, incompleteness experiences are very common and normal. So these are examples of very common incompleteness experiences that people without OCD report having relatively often. So have you ever put on clothes and just felt like they weren't on your body right, they didn't feel right, you had to kind of adjust them to get rid of that uncomfortable feeling? Or when you're locking a door or maybe turning on your car, turning a key, have you ever had the physical sensation or the feeling that you didn't quite turn it all the way, you didn't quite lock it right, or you didn't quite turn the car on? Or when doing something like brushing your teeth, washing your hands, washing your hair, you just kind of felt like it didn't get as clean as it should have. You still kind of feel dirty. These are all examples of common incompleteness, also known as not just right experiences. It's this cognitive and physical sensation that an action that you engaged in wasn't done correctly or wasn't done fully. So this experience of incompleteness also helps to explain why compulsions are repetitive. Incompleteness refers to the sense that an action wasn't done right, or to the cognitive uncertainty that the action was really done because you didn't really have the physical sensation of completing the action. It also can refer to the feeling that something is just like a little bit off or something wasn't done perfectly, which can lead to the need to repeat that action until it feels right. So when someone experiences incompleteness sensations a lot and has cognitive distortions related to perfectionism, so everything needs to be exactly right, I need to be completely sure that this was done right, or responsibility, if this wasn't done right, bad things will happen and it will be my fault for not preventing it. This motivates repetitive actions to make things perfect, or repetitive checking to make sure that things were done right. So again, incompleteness experiences are very common. And in a range of surveys of college students, somewhere between a majority and almost everyone says that they have had these experiences at some point in their lives. For the majority of people, these experiences are cognitive. So I think I didn't lock the door right, or I think I didn't brush my teeth enough. For about a third of people, the experience is both mental and physical. So the feeling of locking the door wasn't right, or the feeling of my teeth is off. So therefore, I believe that something is wrong. And a minority say that they kind of only feel this in their body. It's not even really a conscious thought. It's more of a physical sensation. So what happens? What is the behavioral sequence when someone experiences incompleteness? This figure comes from a study where researchers actually followed people with OCD as they engaged in repetitive compulsive behaviors related to incompleteness experiences and related to cognitive distortions about perfectionism, the need for certainty, and responsibility. So in this example, each circle represents an action that has a function. The smaller dots for the person with OCD represents non-functional actions. So actions that are related to an action that has a function, but that don't actually complete that function. So in the control sequence, these are the steps in parking a car and getting out of the car and walking away. You put the car in neutral, you pull the handbrake. This study was done in the UK, so they have manual transmissions. You turn off the engine, you take out the key, you open the door, you step out of the car, close the door, lock the door. This also is an older study, so they were manually locking the door by putting the key in it, and then you walk away. For someone with OCD who experiences feelings of incompleteness and doubts whether they actually successfully did these actions, for one thing, actions are repeated. So because you don't feel like it was done correctly, you do it over and over again. Also out of logical sequence. So you pull the brake, you open the door, you turn the engine off, you pull the brake again, you put the car in neutral, you pull the brake again, you take the key out, you pull the brake again, you pull the brake again. You're repetitively pulling the brake because the physical action of doing it somehow feels incomplete to you. And you have cognitive distortions that the consequences of not doing it right will be really bad or that will feel really uncomfortable. So those are examples of actions with tails, behaviors that are repeated after the function is completed. People with OCD also engaged in a lot of non-functional actions in the middle of doing these functional actions repetitively. So they may have pulled the handbrake and then kind of pulled it even further just to really feel like it was right. They may have opened the door and then closed it a little and then opened it again and then closed it a little. They may have walked away and then turned around and then turned around again and turned around. So again, not fully repeating the action, but repeating parts of the action to help alleviate that feeling of incompleteness, to help make the connection between their actions and their cognitive sense that the action was done completely or done right. So thinking about incompleteness, this is related to cognitive distortions in that incompleteness experiences are really normal and common, but the cognitive distortions involved in OCD make people feel like the consequences of their actions being incomplete or not just right are more serious. However, there is plenty of evidence that although incompleteness experiences are normal and everyone has them sometimes, people with OCD actually experience them a lot more often. And this has to do with the neurobiological vulnerabilities to OCD, so one of the predisposing factors. Incompleteness experiences result from problems with neural control of action monitoring, error detection, and response inhibition. And these are three components of intentional actions. Action monitoring involves your brain, including the conscious planning part of your brain, the prefrontal cortex, initiating and controlling and supervising goal-directed motor behaviors. Error detection involves your brain processing incoming sensory information from all of your senses, from your eyes, from your proprioception, so your sense of where your body is in space, from your tactile awareness, from your hearing, to help you monitor the action and know if it was done completely or done correctly. And then the last piece in this sequence is response inhibition. Once the action has been done, there are parts of your brain that are involved in shutting the action down so that it's not repeated. So the brain regions that are involved in these three portions of motivated behavior are the prefrontal cortex. This is where the conscious intention to engage in the behavior arises. So when you have the thought, I need to turn off the stove, that thought is a conscious goal-oriented thought that is arising in your prefrontal cortex. In order to actually initiate the movement to turn off the stove, though, the prefrontal cortex has to send a signal back to the basal ganglia, which is that part of the brain that can be affected by autoimmune complications of strep infection, and that's involved in initiating movements. So your prefrontal cortex tells your basal ganglia, turn off the stove. Your basal ganglia tells your hand, reach out to the stove. Fingers close around the stove knob, and your wrist turns the knob. Your thalamus is the sensory relay part of your brain. It's the part of the brain that all of your incoming sensory information synapses on first, and then relays that information to the different cortex regions that help you become consciously aware of that sensory input. So the thalamus is involved in error detection, processing the incoming sensory information to help you monitor and correct the action as you're doing it. So this is how you feel your arm reaching out, you feel your fingers touching the stove, you hear the stove clicking, you see the fire go off. Once that sensory information reaches your conscious awareness in the cortex, it's relayed to the prefrontal cortex, where you come to the conscious realization that the stove is off now. I completed my action. In order for this process to be done, your prefrontal cortex then has to go back to the basal ganglia and say, okay, we did it. We can stop initiating that movement now. My goal is accomplished. And so the basal ganglia then has to inhibit the signals it was sending to the motor cortex, telling the hand, fingers, and wrist to move. If there's a breakdown in communication in any part of that sequence, so between the prefrontal cortex and the basal ganglia, or between the sensory cortices and the prefrontal cortex, this whole system breaks down. So deficits in communication between the sensory regions in the prefrontal cortex leads to deficits in action monitoring, not being totally sure if I did the action, and also in error detection, so not being sure if the action was done completely. Deficits in communication between the prefrontal cortex and the basal ganglia, especially this inhibitory communication that the prefrontal cortex uses to tell the basal ganglia to stop initiating movements, results in deficits in stopping a behavior once it started. So even if you kind of consciously know that the stove is turned off, if your basal ganglia doesn't get that message, it's going to keep sending these motor impulses to your hand, fingers, and wrist, telling you to do it again and again and again and again, until that message finally gets through, that it was accomplished, it was done right, and it can stop now. People with OCD have deficits in this communication that leads them to experience incompleteness more often than other people do. Anyone can have a temporary breakdown in communication, and that leads to normal feelings of incompleteness. But people with OCD have neurobiological vulnerabilities that mean the communication between these regions is overall less efficient than a healthy person. So to put all of this together and help explain why normal intrusive thoughts are experienced as distressing, why compulsions are negatively reinforced, and why compulsions are repetitive, everyone has these intrusive thoughts, and to some extent, everyone has feelings of incompleteness, although not as often as someone with OCD. People with OCD have certain cognitive distortions, including overestimating harm, overestimating responsibility, an inflated need for certainty or perfection, or thought fusion, that cause them to interpret intrusive thoughts and feelings of incompleteness as somehow threatening. So this thought, means that I'm a bad person. This uncertainty that I really turned the stove off means that I definitely didn't turn the stove off and my house is going to explode. Because these normal experiences are experienced as more distressing, any behavior that you do to get rid of that experience, that distress, so suppress the thought, check that you turned off the stove, repeat the action, engage in non-functional actions. All of these things help to temporarily relieve the anxiety, distress, and discomfort that comes from a distorted interpretation of normal intrusive thoughts and feelings of incompleteness. Compulsive behaviors likely become so repetitive and ritualized primarily due to incompleteness experiences. The brains of people with OCD are just not as good at monitoring actions, detecting errors, and inhibiting responses as the brains of healthy people. So compulsions typically aren't done once, they're done repetitively until this communication between the prefrontal cortex and the basal ganglia finally gets through. Okay, so that was kind of an overview of the role of cognitions, behaviors, so cognitive distortions, compulsive behaviors, and underlying neurobiological predisposing factors in explaining the relationship between compulsions and obsessions. I'm going to talk a little bit about treatments for OCD and how these treatments target repetitive behavior as a key perpetuating factor in maintaining OCD symptoms. Okay, but first, pharmacotherapy for OCD is helpful. There's evidence that selective serotonin reuptake inhibitors reduce the symptoms of OCD, especially at much higher doses than are typically given for major depressive disorder. This is likely because dopamine and serotonin are both involved in this communication between the prefrontal cortex and the basal ganglia. And improving serotonin functioning in the brain has been shown to be associated with improvement in OCD symptoms, both as a result of pharmacotherapy with selective serotonin reuptake inhibitors, but also as a result of cognitive behavioral therapy that doesn't directly increase serotonin signaling, but that helps to improve this communication through behavioral mechanisms. The behavioral treatment for OCD is known as exposure and response prevention, or ERP. And this is very similar to exposure for any anxiety disorder. You identify situations that the patient is avoiding because of upsetting intrusive thoughts, and you systematically have the patient confront them. So you have the patient put themselves in situations that activate their intrusive thoughts. You have them intentionally think about Joe Biden naked, and you even raise the stakes and have them think about Joe Biden in compromising situations. Or you have them intentionally touch money, subway poles, and gas pumps that make their hands feel dirty, and then even maybe contaminate themselves more by taking those dirty hands and touching their face, even licking their hands. When I was an OCD therapist, we would often do things like put almonds on a toilet seat and have our patients with contamination obsessions eat those contaminated almonds. So the exposure scenarios that we put people with OCD in are designed to really raise their anxiety by putting them in a situation that they typically avoid in the first place. However, that alone isn't enough to break this connection between obsessions and compulsions, because you have to make sure that when they're in these situations, confronting their intrusive thoughts and activating the anxiety and distress that those intrusive thoughts cause, they're not doing any of the rituals that they normally do to help temporarily suppress the anxiety that comes with intrusive thoughts. This is the response prevention part. In addition to engaging in exposure, you have to make sure that people are completely eliminating the compulsions that are negatively reinforced by reducing anxiety and distress. So getting back to pediatric autoimmune neuropsychiatric syndrome, there's evidence that when people really do develop OCD symptoms in the context of an active strep infection, anti-inflammatory drugs to reduce the inflammation in their brain, antibiotics to treat the infection, and even immunotherapy to treat the autoimmune consequences of the infection of their own antineuronal antibodies attacking their basal ganglia cells. All of these things seem to treat the acute symptoms of OCD that someone might have while they have an active strep infection. And in many cases, this is actually enough to get rid of the OCD symptoms completely. What's maybe a little bit more common, though, is that OCD symptoms will develop in the context of a strep infection. The strep infection will go away on its own, but the OCD symptoms will remain. And this is because, regardless of the precipitating factors, OCD is really perpetuated by cognitive distortions and engaging in compulsive behaviors, which is another form of avoidance. The perpetuation of OCD is really similar to the perpetuation of anxiety disorders. So in cases where OCD symptoms persist beyond the active strep infection, anti-inflammatories, antibiotics, and immune therapy aren't helpful because those are treating the strep infection, but they're not treating the cognitive and behavioral perpetuating factors of OCD. So when PANS OCD persists after an active infection, exposure and response prevention therapy and selective serotonin reuptake inhibitors, ideally in combination with ERP, are an effective treatment. So regardless of what perpetuated or precipitated it, if it's being perpetuated beyond the active infection, it's being perpetuated by the same things that perpetuate all OCD: cognitions and avoidance. Okay, so just an overall review of OCD. OCD is characterized by obsessions and compulsions. A compulsion is any response to anxiety or discomfort that's caused by an obsession, and it's negatively reinforced because it helps to temporarily relieve that discomfort. The common themes of obsessions have to do with harm, responsibility, and doubt, forbidden thoughts, feelings of contamination, and the need for order, symmetry, and perfection. All of these themes of obsessions are also the content of normal intrusive thoughts. Everyone has these thoughts sometimes because the things that people with OCD care about are the same things that everyone cares about. What explains why people with OCD experience these obsessions as more distressing than other people is cognitive distortions. These distorted beliefs about responsibility, the likelihood of harm, thought-action fusion, and the need for certainty help to turn normal experiences like intrusive thoughts and incompleteness into upsetting obsessions that then people are motivated to try to suppress and avoid by compulsive behavior. The reason that compulsions tend to be repetitive, aside from, well, in addition to thought suppression, which involves thoughts rebounding after effortful attempts to suppress them, the other reason is that people with OCD often have a neurobiological vulnerability, a predisposing factor, that means that the communication between their prefrontal cortex, which initiates behavior, and the basal ganglia, which sends the motor signals to actually cause the behavior to happen, is inefficient. So their prefrontal cortex is not good at communicating to the basal ganglia that the action is completed and that they can stop. Or their sensory cortices are not good at communicating to the prefrontal cortex that an action is ongoing or has been completed. So these are problems with action monitoring, error monitoring, and response inhibition. Exposure and response prevention therapy is the effective treatment for OCD because it actually helps to intervene on the perpetuating factors. And the key thing that it does is it eliminates avoidance. It eliminates the role of compulsions in temporarily relieving anxiety caused by obsessions. This causes people to confront their obsessions without doing anything to avoid, and that leads to the normal processes that come with exposure: inhibitory learning or safety learning, and habituation to the anxiety that comes with obsessions. Okay, really quickly, just to kind of introduce the rest of the OC spectrum. From family aggregation studies, where we examine the psychological diagnoses of family members of people with OCD, or the prevalence of OCD in families of people with other disorders, we know that OCD tends to run in the same families as other members of the OC spectrum, like tics, body-focused repetitive behavior disorders, hoarding disorder, and body dysmorphic disorder, which we're going to talk about in the OC spectrum unit, eating disorders, which we're going to talk about in its own unit, and then impulse control disorders, including gambling, shopping, and substance use disorder. We're going to talk about substance use disorder towards the end of this class. And what all these disorders have in common is that they all involve repetitive compulsive behavior, difficulties in inhibiting actions, and in many cases, incompleteness experiences and difficulties in monitoring actions. So the broader spectrum that all of these disorders kind of fall on is known as the impulsive-compulsive spectrum. So difficulty inhibiting behaviors and difficulty stopping behaviors once they've started. All right, and that is the end. Here's some further reading. Thanks for listening.